This morning we have had a case of total knee replacement at the current hospital theatre, one of the theatres I use for my joint replacement surgery. And the lady we've just seen is a 77-year-old lady, very active in life. She actually drives herself, you would imagine, at 77 years. And over the last 5 years, she has noted that she was not able to do a lot of her work because of pain, knee pain. And this wasn't get relieved by medications. So we continued following her. She had been seen in various institutions, but finally we saw her in our orthopedic clinic in Cannon Hospital, where we evaluated and found she had advanced osteoarthritis, which is a degenerative joint disease. What that means is it's a progressive wear and tear of the joints to a point where the only remedy you have is a joint replacement surgery, which is meant to relieve pain and allow the patients to return to their function as much as possible. On average, total knee replacement surgery, assuming there are no complications, no delays, 1.5 hours to 2 hours. On average, total joint replacements are very straightforward procedures. They are open procedures, so there are certain complications that one expects. One among them is bleeding. You can get a lot of bleeding during the surgery or after. Second thing, of course, is the issue of infection. So we guard against that by ensuring that our environment is completely sterile as much as possible. That is the operating room. Everybody is well scrubbed and ready for the surgery, doing a joint replacement, so even our level of sterility is a little higher than ordinary surgery because we're putting in a big implant in a joint. And the other special complications which we associate with joint replacement is higher than normal tendency to develop clots around the legs. Now it's known, this is called DVT, which in full is deep venous thrombosis, where a patient develops a clot because of slow movement of blood in the legs. And this clot can dislodge from that site and travel all the way to the lungs, at which point it really borders on being a life-threatening situation. So we guard against that by taking certain steps. Among them is evaluating a patient preoperatively whether they have other medical conditions which would predispose them to DVT, as I said, excessive clotting of blood, or an abnormal clotting of blood. If they have those problems, then we need to evaluate them and ensure the risks are minimized before we go for surgery. Besides that, after the surgery, then within 8 to 12 hours on routine, that's in my practice, I start my patients on anticoagulant treatment, and this ensures that even if there was a slight chance that the clot is forming, then we don't allow that clot to build up to a level where it is dangerous. And the third thing is I mobilize my patients very early. That is getting them out of bed. Physiotherapy starts moving them around, and that achieves two things. One is we try and increase the flow of blood in the system. Two, we strengthen the muscles of the patient very early. Because it is known, those who have had surgery, those who have had such kind of problems, many times they have reduced their level of activity, so their muscles are also equally weaker than the average. Not necessarily. In fact, we prefer if we may do this kind of surgery without the patient sleeping, and that is we use what we call regional anesthesia. In this case, spinal anesthesia, or a combination of spinal and epidural anesthesia. The latter being a better option because of pain management, because once the spinal gets out of the system, which is in about 2 hours, then you are left with the pain management. And if you have an epidural catheter, and anesthetists are very good with that. They maintain the pain relief for the next 48 hours, and the patient again is able to move around, but pain-free. Yes, there's a lot of anxiety like you'd expect with any kind of procedure, particularly where you get a lot of hammering of bones. So you cut your bones using the saw and that kind of noise. So many times we would give them the natural sleep, sedate them a little bit so that they're able to be relaxed, and they would hear whatever is going on from a very distant point. And that limits or reduces the level of anxiety. Total knee replacement or any other joint replacement in particular is an average of 3 to 4 days in hospital. Thereafter we release the patient home. The wound will take about an average of 10 to 12 days to a maximum of 2 weeks. We expect that wound to heal unless patients have other conditions which may interfere with wound healing. And return to function varies between 6 weeks to 3 months, again depending on a patient, weight of the patient, and the more proactive a patient is, the easier they are to move themselves out of one situation to another until they're able to move on their own. But we do start them on assistive devices. For example, we use a walking frame on the first day because they're a bit unstable, and we progress, that is done by our physiotherapists, progress to using crutches. Finally they'll drop the 2 crutches, it's mean with 1, and until the point where they're now able to walk unsupported, and we give it an average of about 6 weeks.